Dr. Browne operates a general private practice, Browne Psychology Professional Corporation, providing assessments, individual and group psychotherapy, corporate consultations, research, supervision, and training services to clients from diverse ethno-racial backgrounds, gender, and socio-economical backgrounds. She has worked with clients in diverse settings, including community health centers, general hospitals, social service agencies, halfway houses, and community colleges. Please join me in welcoming Dr. Natasha Browne.
Good afternoon, everyone.
Good afternoon.
So we've had such an invigorating day so far, and I am excited and humbled to be asked to come and talk a little bit, briefly, about sorry, Kwam. About Black women and mental health. I think this is a large topic. My hope and my prayer is that I can do it just a little bit of justice with the time that I have. But I think our first speaker, when she spoke about her experience, spoke very eloquently about Black women and mental health and how the stigma of mental health perpetuates particularly with Black women and how that can manifest into a cascading spiral of mental illness, but also the resilience and the strength that she had to overcome and to succeed, I think was very telling and was such a beautiful thing to hear. So I commend you for that as well. What I wanted to do was take us just a little bit on a journey, talk about what's some of the differences between mental health and mental illness. Part of the stigma is that we confuse those things. So I wanted to start off by talking just to define a little bit about what's the difference between mental health and mental illness. So if we just have a basic definition of what mental health is. So mental health is a state of emotional and psychological well-being in which an individual is able to use his or her cognitive and emotional capabilities function in society and meet the ordinary needs or ordinary demands of everyday life. How do we keep ourselves balanced? How do we keep ourselves functioning on a day-to-day basis? This is how we aim to define mental health. Now, the difference between mental health and mental illness. Mental illness, if in terms of just definition, is any of the various conditions characterized by impairment of an individual's normal cognitive, emotional, or behavioral functioning, and is usually caused by social, psychological, biochemical, genetic, or other factors such as infection or head trauma, but also called emotional illness, mental disease, and mental disorder. One of the first things I see in our community is when we say the word just mental health. This is the first place we go. We start talking about mental illness. And actually not even talking about it, we actually step away from it. So the minute we say those two words, when you hear the word mental health, what do you think of? Usually there's either silence, because nobody wants to say anything, or they'll say mental health, no, you're talking about the crazy person down the street. And what that does now is it now entrenches the stigma within our community in regards to mental health. Who wants to speak about mental health? Or mental illness, as we're confusing the two. Because then that stigma now becomes not only perpetuated, but it goes generationally. So it's not just only the person, but it's now parents, cousins, aunts. So it now goes down generations and generations. I don't want to be connected with that. So I'm just not going to say anything at all. That is one of the huge issues in regards to the stigma of mental health, and how do we now open up that dialogue within our community? Where has the stigma come from? So before I even talk about Black women and mental health, I wanted us to just get a bit of an understanding of, we always talk about this stigma. Where has this stigma come from? What does it look like? And why? And my hope is that I can maybe just talk a little bit about what are some of our perceptions of mental health within the Caribbean in particular. Public perception of mental health care remains almost entirely derived from the pattern of mental health service development that focused on major mental health hospitals. So it was based on a premise of psychiatry units in general hospitals, satellite clinics that were geographically dispersed through each island. So because of that framework, this is how we see mental health today in terms of, I usually use the term, and I don't even use the term continuum. It's usually on two poles. The minute you ask or mention the term mental health, it's either you're good, you're fine, or you're absolutely crazy. There's no in between. How could there be an in between with that? It's either two polar opposites. We can't talk about the person who maybe is having just some difficulty struggling on a day-to-day basis and maybe just needs a little help, because there's no room for that. It's either one, you're good and you got to keep everything together. And when we start talking about the Black woman, that's what we end up talking about, is how do we have to keep everything together at all costs? Or the minute that there's a crack, send them to the asylum. That's it. Do not even mention it. And I want to make sure that I shun the rest of the family as a result of that. So now, since these clinics are conducted in the primary care health facilities, they usually reinforce the medical model as the basis for treating mental health. There are several ways to treat mental illness. But when you're solely focused on the medical model, medication and that's it, there becomes a problem. It's based purely on biology and purely a biological medication-based perspective. It doesn't take a look at what are the multidisciplinary factors that are causing this person to express these types of symptoms. But if we give them a pill, that's just fine. And I'm not standing here to say that medication is a bad thing. I think also in connection, in tandem with other things, that in terms of a multidisciplinary model, we can actually look at mental health and mental illness from that perspective. But the difficulty is that when we only purely see things from a medical model, what happens is that there's almost a sense of, first of all, there's a lot of misinformation about medication, but then on top of that, it's also seen as, I have to be dependent on this medication. If it's either that or nothing. If the medication doesn't fix me, then I'm not fixable, because I'm solely looking at things from a medical model. So as I mentioned earlier, what is lacking here is a more whole person approach, and interventions that focus more specifically on psychological and social issues rather than just only medical and psychiatric ones. So what has happened mostly in the Caribbean at this point in time, the care for the mentally ill has been primarily an inpatient. So you have to be admitted to actually get some kind of treatment. And what this is doing now is, if that's what's being perpetuated within the Caribbean community, hence the stigma of mental illness. So you've got large asylum type hospitals, mental hospitals, that continue to be the primary outlet for care for the mentally ill. In the larger islands like Jamaica, Trinidad, and Barbados. Some of the smaller islands as well, like Grenada and St. Vincent, but this seems to be the basis of where people would receive their care. If there's already a stigma around that, if the minute you say that there's a problem, you're going to the asylum, need I say more? Need I say more? So how can we now disclose in the community that we have a mental illness, or that there is a problem where historically, especially within the Caribbean, that this is how we see mental illness? You get locked up in the asylum. So again, this has led now to the maintenance of the pervasive belief system that mental health problems only require significant intervention when the afflicted are at risk to themselves or others. So mental illness is connected with harm, with violence, and only when there's that a significant problem, then that's when we need to intervene. So again, there is no in-between. They're either aggressive, they're violent, or there's continually inappropriate, socially disruptive behavior. That's the only time we would need to intervene. So I'm going to continue to talk a little bit about this history, but I'm wanting to just sort of show a little pathway in terms of when we talk about this stigma, where is it coming from? And if we understand that little bit of history, we can see what we can do to now stop this silence, open up the door, and start to talk. The use of substances remains the most frequently utilized response by people experiencing stress in the population, particularly those in rural areas who are not well served by community health systems. So again, instead of going for help, instead of looking for, somebody to treat or whatever, we're now, because these are not available, the services are not readily available or are scarce, you do have the increased use of different substances to try to calm some of these symptoms. So what does this lead to? This leads to now a treatment gap. Partially addressed by services in other areas, such as the churches, religious organizations, some governmental organizations. But these services are stretched, and on top of that, they're dealing with a lot of different types of victims, different types of traumas, different types of mental illnesses that are being expressed, that sometimes, the services cannot reach everybody, or they don't necessarily have the capacity to deal with. As mentioned earlier, again, there's also a growing suspicion about the use of medication for mental health issues, as perpetuated by medical and pharmaceutical industries, which champion the medical model for psychiatry. So you have now, on top of all of this, you have now a lot of people that may, for example, need medication, or would actually, work very well with some type of consultation for medication, but then there's a stigma with that as well. A lot of misinformation about that as well. So there's a growing suspicion, and then you have people that will not want to seek services or even seek the treatment as a result of that. Again, partially due to lack of a balance of other mental health professionals as well. So what happens is that you have services that are very overwhelmed, and then there's just not enough of other types of professionals who can possibly do the work. Psychologists, psychiatrists, social workers, psychotherapists, occupational therapists who can do some of that stuff as well. So again, systems that are very overwhelmed and underutilized as a result. But as these services become more accessible, there's a growing demand for counseling services. But the thing is that what we have to look at, especially within the Caribbean community, is we don't have to only look at psychiatrists, psychologists. There's a growing number of how do we utilize other services from other areas, such as the churches, such as other community groups. When I talk a little bit about the culturally adaptive CBT model, this is what we're looking at as well. It's not only that it has to be clinicians. How do we now partner and utilize other services such as the churches or other organizations so that you're able to get the best care for that individual? So in terms of the community, in terms of the stigma, in terms of the silence, the inability to further push the mental health agenda within our community as a result of opening up that discussion. So that discussion, I believe, I absolutely agree with you. It has to be had, it has to be understood, but it also has to be in a place that we are feeling safe to do so. And that, I think, is the hardest part. But I think it needs to be done. Because I think a lot of times when we start talking about running away from that kind of discussion, this is what entrenches sort of our issues as Black women. So I think safety is a huge thing.
Okay, final question from the lady in the green at the back. So what's the lady in green? Okay. I'm gonna let you go ahead, and that'll be it.
Okay, so I just wanted to comment that the delay in treatment for Black women getting services is often due to the fact that we normalize emotional distress.
Yes.
Because we do have hard lives, and because we face poverty and so many other
Absolutely.
injustice.
Yes.
So that's the one thing. And I just also wanted to say that the word mental illness, in itself, the word illness, does suggest pathology. Some people really struggle with that.
Yes.
So language is extremely powerful, and we can be cognizant of how we use language.
Yes.
I've not once heard anyone say that, gee, maybe this person is struggling with a mental health issue. Okay? And I think that just even when I talk to my clients or I talk to their family members, they feel a little bit better when I say mental health issue, or I say emotional distress, or unwell.
Yes.
You know? So if we're saying that a lot of mental health issues are not disease, but they're caused by all these other social determinants, then perhaps we can use words that reflect that.
Yes.
Okay.
I agree. Absolutely. Semantics are a huge thing. All right. Thank you again.